Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place where I get to spoon feed you guys the latest and greatest of emergency medicine. Now, this is the audio version of the past week's summaries, which this week were brought to you by our authors, Joshua Belfer, Rebecca DeFabio, Ketan Patel, Megan Hilbert, Samuel Rouleau, and Clay Smith. And so we have the first article titled Traumatic Pneumothorax and Hemothorax, What You Need to Know, out of the Journal of Acute Care Surgery. Now, of course, pneumothoraces are a pretty common presentation. About 1/3 of thoracic trauma patients will have a pneumothorax or a hemothorax or even both. And that's quite a few patients. The authors just wanted to summarize some of the data out there for traumatic pneumothoraces and hemothoraces. Now, EFAST is going to be a good diagnostic tool, and it's going to be about twice as sensitive as chest x-ray for diagnosing a pneumothorax or a hemothorax. 91% sensitive versus 47% for a chest x-ray. That's pretty good. Both of them, however, have near perfect specificities, which is great. There are, of course, other clinical findings which might lead you to think that your patient might have, say, a pneumothorax. They're hypoxic, they have crepitus when you feel their skin, they have tracheal deviation, or they're just unstable. In all the hemodynamically unstable patients, you should be putting in a tube thoracostomy pretty much as soon as possible. You can do a finger or just a needle decompression, but preferably put a tube. In stable patients, on the other hand, the decision to observe versus putting in a tube is a little bit nuanced. There are some ways to calculate how big the pneumothorax is. So if you have a calculation of more than 20% on the chest x-ray, or you have a greatest diameter more than 35 millimeters on the CT scan of that patient, in those patients who have greater than that 20% or 35 millimeters, these authors recommend that you put in a chest tube. If it's smaller than that, then most of those patients can get away with just observation of the pneumothoraces. However, still around 10% of those patients who are observed will fail and still need a tube. For any patient that you're just observing, they should get a chest x-ray at between 4 and 6 hours and then another one at 24 hours. The treatment approach generally is pretty similar for a hemothorax. Again, if they're unstable, you just put in a tube. And if you do put in a tube and they drain more than 1.5 liters of blood or more than 200 milliliters per hour for 4 hours, then you should consider that patient for an operative thoracotomy. Now, in stable patients, most of these patients should probably be getting a CT, and if that CT scan shows that there is less than 300 milliliters of blood, then you can consider that patient for observation. If they have more than that, then the authors recommend that you put in a tube. The authors recommend, based pretty much solely on their own practice, that you do irrigation with 1 liter of warm saline in any patient that has a hemothorax. Although they didn't seem to really evidence-base that one, it was just their practice. Justified that they believe that it reduces the rates of retained hemothoraces and the need for secondary procedures. Now, the real hot topic question that's been in the last couple of years is how big of a tube should you be placing in your patients? And it seems to be that if your patient is stable, then there's really no reason to put in one of those big tubes. In a stable patient, you can put in like a pigtail, something that's 14 French or smaller, and they seem to have equal outcomes. They cause less pain and have less complications as well. So in stable patients, small tubes. As for antibiotics, well, before you put in your tube, it's recommended that the patient get 1 prophylactic dose of cefazolin, if possible, particularly if it's penetrating trauma that's caused the injury. Less useful for blunt trauma, but still you should be giving it if possible. The authors even made some comments about when patients can travel after these injuries, but it seems that there's no concrete advice. The time to wait seems to be anywhere from 3 days to about 2 weeks. You'd probably want to check with your airline to see what they recommend. Or your insurance company, one of the two. All right, and that's all the authors really had to say about thoracic trauma. In a spoonful, we just did a quick review of everything pneumothorax and hemothorax in trauma. And then we move on to the second article. which was titled Kinetic Changes in High Sensitivity Cardiac Troponin for Risk Stratification of Emergency Department Chest Pain Patients, out of the American Journal of Emergency Medicine. Now, there is most certainly no test more important for a chest pain patient than a troponin level. The troponin level is really going to help you decide what happens with them. I'm not a huge fan of the heart score or the HERS score because I don't think a lot of that changes management very much. If you're not having a heart attack, then you don't really need an angiogram. If you're not having heart failure of some kind, then you're not going to need a cabbage. And otherwise, the best thing that you can do for these patients who don't have any heart failure and aren't having a heart attack is diet and exercise, essentially. Try to control those risk factors. But that should be the case for everybody. Everybody should eat well, have a healthy weight, and try to target all of those things that they can control. They should try to do that all the time. So we should be telling that to all of our patients. Of course, if I strongly suspect that my patient does have some kind of coronary artery disease, then perhaps they should be on an aspirin, but that's mostly about it for most of these patients in terms of primary prevention. So knowing the rest of the HERS score really doesn't change my management that much, but the troponin certainly will. And whether or not the troponin is going up or going down or staying the same, well, that's probably something important to keep in mind. A lot of the time we are getting serial troponin measurements in the emergency department, and so we are seeing trends in them. How does that relate to the prognosis of these patients? Specifically 30-day MACE rates in adult patients at a single center. Now, the authors broke up patients who came into the emergency department with some concern for some kind of cardiac disease into 3 groups. Either they had no change in their troponin levels, they had a rising pattern, or a falling pattern. Now, here they've got specific nanograms per liter for their troponins, and it's 15, which is their cutoff. But their 99% of normal was in the 70 range for males and 50 for females. So it's going to depend on your hospital, your protocols. That's about 20 to 30% change from the 99% of normal. In total, they had over 4,000 visits, and 34% of those visits had a rising troponin. Unsurprisingly, the patients with a rising troponin had the worst MACE outcomes, with an adjusted odds ratio of 7.7 for having 30-day MACE outcomes. Interestingly, patients with a falling pattern also had a worse prognosis. Not as bad, but an adjusted odds ratio of 2. So in populations where you see that their troponin is going down, you also have to be concerned for those patients. And we should already know this. If you recall the 4th universal definition of acute myocardial infarction, you'll know that it is stated as the clinical evidence of an acute myocardial infarction with a rise or fall of troponin values with at least one blah, blah, blah symptoms of MI, ischemic, ECG, Q waves, or echo findings, essentially, or a thrombus on angiography. But what I'm talking about for the definition there is that it's a rise or fall that is built into the definition. And so all of these patients, since they were above the 99th percentile of normal and came in with some kind of symptoms concerning for a myocardial infarction, all of those patients, even with falling values, technically had an MI. Now, this trial could have corrected for a few other things and kept things in mind, like what if that patient had chronic kidney disease and you gave them a fluid bolus? Maybe you've just diluted their troponins a little bit and their baseline was already kind of high. This wasn't really adjusted for in this study. But it is worth saying, and it's worth studying in general. So take a look at your whole patient and just keep in mind that even troponins that are going down, any troponin that is kinetic is probably worrisome. All right, in a spoonful, if it's going down, it must have gone up. Dynamic troponin levels, no matter the direction, are predictive of 30-day MACE outcomes. Of course, though, if their troponin is rising, that's worse. Okay, that's all the articles we covered from this week. Let's do a quick wrap up of everything we talked about. From the first article, we did a review of traumatic pneumothoraces and hemothoraces. POCUS does well to get the diagnosis, and if your patient is stable, they can have a pigtail put in. From the second article, while a rising troponin is the worst prognosis, a falling troponin isn't that reassuring, and you should still be worried about those patients. If you are hearing this right now, then you are not a part of the members feed and you missed 3 articles from this past week. What were those articles that you missed? Well, one was about how big of a pneumothorax you can observe in children. The second was about the dangers of the extremes of potassium values. And third was about the VEXIS score and whether or not it can predict mortality in the emergency department. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.